thyroid cancer. Ultrasound is an ideal imaging modality for detections and assessment of thyroid nodule. It is easy to perform, widely available, and do not involve ionizing radiations. The use of high-frequency transducer has significantly improved the spatial and contrast resolutions in evaluating superficial structure, including the thyroid gland. The images are captured in real time, so they can show the structure and movement of the body's internal organs. They can also show blood flowing through the blood vessel. One obvious advantage of ultrasound over other imaging modality is ability to combine with fine needle aspiration cytology (FNAC) to increase the diagnostic accuracy. The use of ultrasound in thyroid cancer imaging is dealt with in more detail in the later part of the review, which are detections and characterizations of thyroid cancer, detections of cervical nodal metastases to determine if a lump in the neck is arising from the thyroid or an adjacent structure, follow-up of patients after treatment for early detections of local or nodal tumor recurrences, and provide imaging guidance for FANC or biopsy. An advanced ultrasound machine with a high-frequency transducer, which is 7 to 15 MHz, is the basis equipment required. High-frequency transducer allows superior near-field resolutions and form the basis of characterizations of benign and malignant thyroid nodule. The color Doppler is possible to directly observe blood flow. The colors represent the speeds and directions of blood flow within a certain area of the image, which is color box. The color box is divided into small sample regions, which is 1 color pixel. When using color flow and power Doppler, the machine should be calibrated to allow depositions of slow-flowing vessels in the head and neck. In evaluating the thyroid gland, scanning in the transverse and longitudinal plane is the most commonly used method. Real-time imaging of thyroid lesions is performed using both grayscale and color Doppler technique. Adequate extensions of the neck is required to ensure complete assessment of the inferior aspect of the thyroid gland, though this may be difficult in the elderly. Adjusting the depth and gain setting is essential to ensure the whole of the both lobes and the superficial isthmus are fully assessed. To evaluate large goiters, a lower frequency, which is a 5 MHz transducer, may be required to assess extensions into the retroternal regions. Ultrasound examinations of the thyroid must always include a detailed examination of the neck for any cervical lymphadenopathy. Metastatic cervical lymph nodes are frequently seen in thyroid cancer and may affect the surgical management and prognosis of patients. An ultrasound guided for needle aspiration biopsy uses sound wave to help locate a nodule or abnormality within the thyroid and remove a tissue sample for examinations under a microscope. The procedure is less invasive than surgical biopsy, leaves little to no scarring, and does not involve exposure to ionizing radiations. During a fine needle aspiration biopsy of a thyroid, a small sample of tissue is removed from the thyroid gland and examined then under a microscope to determine a diagnosis. An ultrasound of thyroid produces picture of the thyroid gland and the adjacent structure in the neck. The thyroid gland is located in front of the neck, just above the collarbones, and is shaped like a butterfly, with one loop on either side of the neck connected by a narrow band of tissue. It is one of the 9 endocrine glands located throughout the body that makes and send hormones into the bloodstream. Carcinoma appears as an irregular solid or 60 mass or nodule in a normal thyroid parenchyma. Despite its well-differentiated characteristics, papillary carcinoma may be overtly or minimally invasive. The second most common type of thyroid cancer, making up about 10 to 15% of all thyroid cancers. Follicular carcinoma is called a well-differentiated thyroid cancer like papillary thyroid cancer, but it is typically a bit more malignant than papillary carcinoma. It can spread into lymph nodes and is also more likely to spread into blood vessels. Cancer is found in about 4% of all thyroid cancer cases. It's more likely to be found at an early stage because it produces a hormone called calcitonin, which doctors keep an eye out for in blood test results. Anaplastic tumors have a high mitotic rate and frequently invades the local blood and lymphatic vessel. Frequently, the ultrasound will allow local invasions of the thyroid mass into muscles, trachea or esophagus, as well as abdominal lymph nodes and around the thyroid gland. The benefit of thyroid ultrasound is non-invasive, painless, widely available, easy to use, less expensive than other imaging methods, safe and does not use radiations, gives a clear picture of soft tissue, and provide real-time imaging. For the risk of thyroid cancer, there is no risk because the standard diagnostic ultrasound has no non-harmful effect to humans.